Hi, this is Fernando Gomez Sancha, and this is an interesting case of a man who had 5 previous prostate operations. He had a PVP, then a prostatic artery embolization, then he had 2 TURPs and then another PVP, and he was complaining of all the constellations of urinary symptoms. And what we thought by ultrasound is that this man still had anterior apical residual tissue. So we did this cystoscopy, and we could see on ultrasound that there was still adenomatous tissue remaining, mostly apically and anteriorly, like you can see in this ultrasound. So we decided to go for it and try to remove this anterior tissue that was blocking the passage. You can see that the bladder neck is wide open, but there's still tissue anteriorly. So it took us, less than 15 minutes to do this, but it really changed the symptoms of the patient, who is now doing really well. And this is common. Many times I think the fear of going into the sphincter and damaging continence might produce these situations where anterior tissue is obstructive. So we have to do a careful delineation of the apex. You see there's no clear transition between the sphincter and the anterior part. So you have to just go for it. Try to understand where the edge of the sphincter could be. Sometimes you can see a little pit between the apical anterior tissue and the anterior part of the sphincter. In this case, there was no clue of where the limit would be. So I did an initial careful marking, the white line, as I call it. And then, as always, when we do redo cases, I try to explore how much BPH tissue there is left circumferentially, not only trying to remove whatever obviously remains, but always trying to explore a little bit of the also the posterior tissue, because sometimes we find that there is residual tissue. On the other hand, and you can see there's a bump of tissue there that is probably BPH residual tissue, which is amazing. After so many goes to the prostate. So also here I was a little bit concerned about a possible bladder neck stricture after anything we do. So you'll see how things turned out at the end. In this case, I was using the classic holmium, the classic 100 watt laser from Luminis that we still have and we still use sometimes, especially when we are very busy and we work in 2 different operating rooms. So we might use the different consoles for different operating rooms, so we don't have to keep moving stuff from one place to the next. So here you see that I'm trying to look for orientation. I'm trying to see how the tissue looks like when we come upwards from the lateral plane, trying to understand. So very carefully coming up, you see, coming up. Trying to follow the contour, and then of course going to the apex to check what happens. I think I was having some trouble with the fiber in this case, so it probably would have taken 10 minutes if we didn't have this fiber going in and out thing. But as you can see now, here I'm putting the fiber in again, I think. Yeah. So there we are, trying to understand, trying to be careful anteriorly, but of course we don't want leave more tissue. No, this man had already too many operations on his prostate, and yeah, this is a not very common, but this is a situation we see sometimes. And you know, if you do a cystoscopy, you see the bladder neck open, and maybe you don't realize that what the bump you're seeing above is not just a sphincter, but there is residual BPH tissue there that is behaving obstructively. So I think the transrectal ultrasound is a nice idea to check in these cases, and if there is remaining BPH tissue, which would be extremely easy after, you know, TURP, for example, then it's worth going in and giving it a go again and removing this anterior tissue. I thought it was an interesting case to show, not very difficult, but again, it's we have a tool, which is this laser. We have anatomical knowledge, and then we have some, you know, we have to face the cases that come. You know, this patient was saying to me, you know, I have had 5 operations before. It's absolutely crazy. Please help me, you know, because I cannot live like this, you know, and very frustrated. Actually, he came from abroad, and he had seen some of these videos, and he was interested in this ultrasound evaluation. Again, I had some trouble with the fiber, so that was quite slow, and I'm sorry for that. Fiber in and out thing, there it is again. And but as you can see, now we progress like as usual. Now the apex has totally been released from the sphincter anteriorly, and now it's a matter of going around and dissecting the plane, letting the laser do the dissection. Carefully, of course, there is some fibrosity, you know, of the tissues after, you know, so many things done to this prostate, and the solution I found at the end to this, what I was meaning about preventing a bladder neck stricture, was to try to leave some of the bladder neck untouched, so that hopefully it will not contract later on. So you'll see that instead of a, you know, completely en-bloc operation, I did you know, half moon resection, mostly of the anterior tissue, preserving some of the bladder neck. And we had a similar case of a patient who was self-catheterizing because he couldn't pee, you know, and he had also two TURPs before, and they told him, you know, the bladder neck is wide open, you have a weak bladder. But we did a urodynamic testing, and he was clearly obstructed, and there was a bladder contraction. So we removed the tissue as well in the same fashion, and he, after 4 years of self-catheterization, he was able to void normally. So for us, it was a big success, and the patient couldn't believe, you know, that, because he had assumed that he had to self-catheterize for life. So interesting stuff. I think we are learning a lot of anatomy with this en-bloc technique, and I think it's a very, very useful technique, and the, you know, anatomic aspect of it, I think it's extremely attractive, no, trying to get rid of the problem once and for all. So here again, trying to follow the anterior line, you know, I always trust my lines a lot. Here I'm trying to remove that bump that we saw before, apically and posteriorly, but here again I will try to preserve a little bit of the bladder neck at 6 o'clock, so that the chances of a stricture after this are less. And there it is, trying to connect the lines and trying to connect the opening of the bladder neck in this side with the opening on the other side. And there it goes. I think that's the end of the... And now we will have a look with transrectal ultrasound. What I do is I keep the endoscope inside the bladder, so the bladder is filled. Of course, I retract it so I can see the fossa. Maybe keep the endoscope in the urethra. And at the same time, we introduce a transrectal ultrasound probe to have a look at things and how they look. And I think it's a very nice view of, you know, the difference pre and post-operatively of how the apical tissue looks. I think there's still a sphincter there, and the patient was perfectly continent. So I did a little bit of hemostasis to morcellate the tissue out, and then we did the ultrasound to check that the tissue had been removed completely. There it is. That's the external sphincter, and now there's no curtain, you know, coming down from the. So there's no anterior tissue coming down. Here I was opening the bladder neck a little bit on that side, maybe to get some wideness of the bladder neck. Yeah, some hemostasis, and then the morcellation of the very small piece of tissue. As usual, which was extremely fast, of course, because there was only 2 or 3 grams of tissue, and I promise it's going to end very fast. So bear with me to look at the ultrasound. Well, this is a change of instrument. Face. There we go. That's the nephroscope coming in, which was a little bit damaged, I think, because there's some funny optical effect. No, it looks good. And that's the morcellator blade, and that's the bit of tissue we took out, which was almost instantly morcellated. So I'll show you now the transrectal ultrasound postoperatively. And typically we have a sterile sheath covering the transrectal ultrasound. You can see the apex. You can see the verumontanum, this beautiful image that shows that all the apical tissue has been removed anteriorly. Here, I think I was telling my nurse to change the view to the longitudinal view, and there you can see how all the tissue that was there anteriorly has gone. So I hope you enjoyed this short video. All the best. Bye-bye.